Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay. I welcome one and everyone who's there in the class today. It's a Sunday afternoon, and I understand that you're taking out this time from the otherwise free day. You've not gone, many of you have not gone for the outing in the evening, but don't worry, it will take me maybe an hour or so, and you will be done with a very important chunk of your syllabus, which is the antepartum haemorrhage. Let's start with the introduction. What exactly is it? So it's a condition which complicates the pregnancy, responsible for considerable adverse perinatal outcomes. And when I say perinatal, I'm talking about not just the neonate, but even maternal mortality is very high at APH. Bleeding from or within the genital tract after 20 weeks of gestation, but as per the latest definition of GTG, it is after 24 weeks of gestation, is called as APH, antepartum haemorrhage. Now you are going to tell me, but I think I've already discussed it, one of the question papers in the exam. What are the different major causes, 4 major causes of antepartum haemorrhage? Come on, I need an answer quickly from all my students who are there in the class. So what do you mean by, what are the 4 different causes of APH? Yes. Okay, guys. Very good. Deepti is the fastest in typing, I think. The placenta previa, abruptio, vasa previa. Very good. I said that in my while I was discussing the answer bank, I guess. That is the time I was talking to. And any local cause. You can call it a local cause. It could be cervical erosion, it could be cervical cancer, it could be vaginal discharge or vaginal infection, a local cause. Very good. That's fair enough, Deepti. Thank you so much for being so quick. And we move ahead. So here we're going to talk about placental abruption, placenta previa, vasa previa, and where is the other one? Where have I written that down? So local causes, somewhere over here. I've written down local causes, though it's understood, but see, lesions. Local genital tract lesions, like the lesions and polyps. And here you have vasa previa, which is an again important entity because of which. So what exactly is vasa previa? Anyone? Quickly tell me, what is vasa previa? Yes, I'm done highlighting what I wanted to. And by the time I need an explanation, what do you mean by vasa previa? You know what is placental abruption, okay? Bleeding due to the separation of a normally situated placenta before the delivery of the baby. Placenta previa, you know that the placenta is low-lying in the lower uterine segment. So what is vasa previa? It is the bleeding from the vessels of the cord when they're coursing through the membranes due to the cord insertion, which is distant from the placental area and is usually seen intrapartum at rupture of membranes or even at the time of. I'll tell you what exactly it is. This is a very confusing statement. Vasa previa means a leash of blood vessels, a leash of fetal blood vessels, which is traversing over the internal os. Either due to a different position of the placenta, like when you have a centuriate lobe, so it's traversing from here to there. They are fetal blood vessels, remember that. So the blood that will be lost will be that of the fetus and not of the mother. So sudden fetal distress can take place at the time of rupture of membranes. And otherwise also, even if it's not traversing, on top of the cervix, it can still cause a lot of, distress to the fetus, because finally whatever blood is being lost is because of the baby, is because of the fetal side. So vasa previa is actually this. Now here I have a small figure. I'll just enlarge it so that everyone can see it properly, and then I'll change. Wait, guys, and then I'll change the figure. See, now can you see this? This is abruptio. Okay. This is abruptio because it's a normally situated placenta, and there is a retroplacental shearing or retroplacental separation. This is a placenta previa because it's covering the internal os. This is one more reason of an antepartum hemorrhage. Then you have certain local lesions, okay, over here. So you can have cervical erosion, cervical polyps, fibroid, cervical fibroid, or maybe carcinoma cervix, carcinoma endometrium, which is metastasized to the cervix, so on and so forth. And this is vasa previa. Okay. Now do you understand the meaning and the importance of vasa previa? Okay, so that was the importance of vasa previa, and it's very, very important clinically. Now, clinical presentation, what do you have? There are 7 slides on just clinical presentation alone, and how clinical presentation becomes very, very important in terms of understanding and managing cases of abruption. So the typical presentation with an established pregnancy of more than 20 weeks is per vaginal bleeding. So the moment you have a per vaginal bleeding, you know that this is a case of abruption. That's what you call it, until unless you know the cause. And clinical history is very, very important to evaluate the mother better. And this assessment should involve the following points. What you need to know is the amount of bleeding, the source of bleeding, and the current hemodynamic condition. So there are 3 S: sweating, syncope, and altered sensorium. So the patient is gasping, sweating, she's about to faint, there's altered sensorium, that means she's lost a lot of blood. So such a patient has to be taken on priority basis, always. Presence or absence of pain associated with bleeding, either continuous pain, which is there in abruptio, or intermittent pain, which is there in labor. Any risk factors for APH, like maybe preeclampsia, or a previous history of abruptio, or a low-lying placenta. Fetal heart activity, movements, jeopardy, gestational age, number, and abruption rates for vasa previa. And of course, if you have a history already of LGT, some local lesion. So there are points to ponder immediately on admission. First of all, the amount of bleeding, the cardiovascular and the hemodynamic status, the source of bleeding, and certain lab assessments, like you want to see the complete blood count, you want to arrange for the blood, you want to go for seeing what are the current renal parameters, because she can have deterioration in minutes. Renal parameters, liver parameters, if required, ABG analysis, required maybe, the coagulation studies, and the studies for DIC. Condition of the fetus, so CTG of the fetus as well. Of course, an ultrasound to see what is the cause of bleeding, where the bleeding is coming from. And of course, the obstetric parameters, like if the uterus is contracting, if the uterus is tender, what is the level of cervical dilatation, if at all these things. So the first step is the assessment of the blood loss, okay? And how will you do that? Pallor, pulse, pressure. So you need to know if the patient is pale, if the patient is having tachycardia, if the patient is having no BP, because the 4th P is actually the pain. Okay. The presence of not so severe light bleeding or blood-stained discharge is a bloody show due to the release of cervical mucus plug as a result of cervical dilatation. We all know about that. Show is a sign of labor. Cause of concern is gestational age less than 37 weeks. Bleeding is intermittent, can be due to the stretch of cervical canal or marginal separation of the placental edge. Such a bleeding can also be from polyp, infection, cervicitis, or careful perspective examination can help reveal any lower genital tract lesion and not so severe light bleeding. See, not so severe light bleeding, blood-stained discharge. This has many reasons. So it could be just a show, it could be a local lesion. So bleeding from here is very intermittent, self-limiting, and it does not compromise the hemodynamic status of the patient. But then you have, this is just a depiction. Presentation of bleeding for each category, how does that look? Can you tell me how does, okay, let me just ask my students, okay, very specific, tell me, placenta previa bleeding, how does that clinically show? What will be the symptom that you will be asking the patient, or what symptom are you looking forward to diagnose it? Oh, no, this is not abruption, this is placenta previa. Tell me that. This is MBBS level, guys. Come on. Yes, bright red, painless bleeding. Very good, Deepthi. Deepthi is on fire. Great. I'm very, very happy with this response. Okay, and tell me, what is the bleeding of APH looks like? Just abruption, I'd rather say abruption. All this is APH, but let's call it abruption. So this can be, this can be brown also. This can be bright red also. This can be, it's mostly clots, and usually she will have pain, isn't it? Yes. So tense uterus, painful uterus, tender uterus, and then of course bleeding can be of different levels. It could be bright red, it could be dark red, it could be clots, it could be brownish red, all this.